As an anesthesiologist, when you run into an issue like difficulty ventilating, is the first thing that you do create a list of things that could be causing or contributing to that?
Right. You develop a differential diagnosis very quickly. List of possible things that might be occurring, and then you work through the most probable and treat down the line.
And in your review of the records, were you able to determine whether Dr. Kaufman did that?
Yes, she did. Immediately after placing the single lumen tube, she gave albuterol puffs down the tube. Now that is our first line treatment for bronchospasm.
And why is it the first line treatment?
Because it's the most effective, most potent. So you are delivering a drug that acts directly on the smooth muscle in the lung tissue. So you're actually targeting, the medicine is targeted specifically to relieve smooth muscle constriction in the lungs.
And explain to us how that albuterol is delivered to the patient.
It's by inhaler. So you are trying to get the medication, if you think of the lungs as like a giant tree, when you have an asthma attack or bronchospasm, the problem is in the smaller branches, if you will. And so you've got to have something that's sort of small to get down into those really small, fine branches in order to treat what's causing the issue.
Okay, and so tell us how the albuterol works.
So it is disseminated through the endotracheal tube as a fine mist, and then it attaches to the smooth muscle in the lungs.
So is it a direct cause and effect relationship that goes down the tube and actually physically attaches?
That's a good way of thinking about it.
All right. Was giving albuterol an appropriate response to the increase in peak airway pressures and the difficulty ventilating that Dr. Kaufman encountered?
Yes.
At that point. In addition to the albuterol, what else did she do to treat for bronchospasm?
She turned up the sevoflurane. To cause more bronchodilation with her inhalational agents, and the patient was on 100% oxygen, and she hand ventilated the patient in order to try to physically break the bronchospasm.
We talked a few minutes ago about the fact that Dr. Silverman came to the operating room in response to a call for help. Have you had the opportunity to respond to a colleague's call for help in the course of your practice?
Yes.
That's something that happens from time to time?
Yes.
Okay, in this case, once Dr. Silverman arrives, what happens next?
Well, from my understanding, once Dr. Silverman arrives, he gets sort of basically a summation of what's going on. He notices that the saturation is in the 70s, and she's having difficulty ventilating the patient. Again, there's no end-tidal CO2, so when you're thinking of your differential diagnoses, there aren't too many things that will give you zero end-tidal CO2. So he's working through that differential diagnosis and thinks that possibly the tube is kinked or plugged, or there's something wrong with the placement of the tube, because he was not present to watch the tube actually go through the vocal cords when Dr. Kaufman placed the tube. So he removes the tube and replaces it under direct visualization with the glide scope.
And do you have an understanding of what Dr. Kaufman was doing to troubleshoot the problem while Dr. Silverman was intubating?
She was giving more inhalational agents. She was also still trying to give puffs of albuterol down the tube, and just keeping the anesthetic as deep as possible and trying to physically break the bronchospasm.
Dr. Silverman pulled his first tube and replaced it. Do you believe that was a reasonable decision by Dr. Silverman?
I do.
Can you explain why?
Again, they had zero end-tidal CO2. It's rare. I've never seen bronchospasm present with zero end-tidal CO2. So, and they've been giving the medication that would presumably break the bronchospasm. So they've given albuterol. They've deepened the anesthetic. She's on 100%. They're trying to break it physically with the bag, with hand ventilation, and they're getting nowhere, so there must be something else. There must be some other cause, and you cycle back to your original list of differential diagnoses and troubleshoot it again.
Okay. How much time does it take to pull and replace a single lumen tube?
Oh, it's minimal amount of time, 30 seconds or so.
Okay. Is there any quicker or easier way to troubleshoot issues in terms of mechanical obstructions with the tube?
I don't think so.
Do you believe that Dr. Silverman's decision to spend 30 seconds and pull that tube and reintubate Ms. Palacios caused or contributed to her neurological injuries in any way?
No, because they weren't moving any air at all. Her end tidal CO2 was 0, so the 30 seconds that it took him to remove and replace the tube was negligible compared to the rest of the picture.
Do you know how Dr. McNeil and Dr. Moore first became involved in the case?
My understanding is that they responded to a call for help.
Okay. And do you know when they entered the room?
That's difficult to say. There seems to be some discrepancy between the physicians who were actually present. The only thing that I can say is that Dr. McNeil and Dr. Moore arrived roughly about the same time.
Okay. Does the timing of their arrival, for example, if they arrived before the code was called or after the code was underway, does that impact your opinions in any way?
No.
Tell us what Dr. McNeil and Dr. Moore's responsibilities were and how they were assisting once they got into the room.
It's my understanding that when Dr. McNeil came in the room, they were in the process of trying to break the bronchospasm, and Dr. Moore came in and decided that he would do a bronchoscopy. He put the bronchoscope down the endotracheal tube but was unable to see anything, and so he questioned whether or not the endotracheal tube was actually in the trachea. And to assure Dr. Moore that they were actually in the trachea, they removed and replaced the tube so that he could see on the glide scope the tube going into the trachea.
And that was Dr. McNeil who did that,
That is correct.
Do you have an opinion as to when in the sequence of events Ms. Palacios' heart rate dropped into the 20s?
My opinion on that is that it dropped when they called the code.